My name is Adriana J Connell, and my student ID is 58918793. The lesson is 427236, and my email address is ajconnell67 at outlook.com. It is AJCONNELL 67 at outlook.com. Scenario 1. Digestive system gastroenterology. Gastric ulcer with massive upper gastrointestinal bleeding. A 50-year-old female was rushed to the emergency department following 3 bouts of hematomasis and a single bout of melania. On examination, she was tachycardic and hypertensive with 121 beats per minute and a 90/50 mmHg, respectively. She manifests pallor with no icterus. She is apneic and normothermic, but reports intermittent periumbilical tenderness. Medication history reveals occasional intake of non-steroidal anti-inflammatory drug, naproxen 250 milligrams for arthritis management. On admission, her complete blood count reveals a hemoglobin level of 5.1 GDL and hemocrit 32%, prolonged protobin time, and a positive Wyatt test. All other laboratory studies were within normal limits. Based on this clinical presentation, intravenous fluid were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and an upper gastrointestinal endoscopy was performed, which reveals a 1 by 1 centimeter hemorrhagic gastric ulcer. The bleeding ulcer was cauterized and biopsies were taken for Helicobacter pylori, the results of which are negative. Proton pump inhibitors were started and she was discharged after 2 days in a stable condition. Scenario 2. Diabetes subsequent diagnosis. Uncontrolled non-insulin dependent diabetic mellitus. A 50-year-old female with non-insulin dependent diabetic mellitus was seen in her primary care provider office with reports of diminished sensation in both feet and occasional blurred vision. The client admitted to problems adhering to her prescribed dietary and medication regimen. She does not exercise regularly, takes her medications only when she is reminded, and she doesn't watch her diet. She denies dyspnea, polyphagia, polydipsia, polyuria, and diaphoresis. The client had history of non-insulin dependent diabetic mellitus for 15 years and dyslipidemia and hypertension for 8 years. She had laser photocoagulation for retinopathy in the past year. She is on metformin and glipizide for control of hyperglycemia and hydrochlorothiazide and ramipril as antihypertensives and atorvastatin for hyperlipidemia. Upon examination, her blood pressure is 185/98 mmHg. Fasting blood glucose is 265 mg/dl. Hemoglobin A1c is 9%. Serum blood urea nitrogen and creatinine at 53 milligrams and 4.4 mgd respectively. Urinalysis and 24-hour urine collection uncovered traces of protein and urinary albumin secretions, rate of 255 mg per day, leading to a diagnosis of microalbuminuria. Nerve conduct studies and electromyography confirmed diabetic neuropathy, decreased visual acuity, and a new extensive reticular vascular growth were revealed through the ophthalmologic exam. Based on the client's typical presentations and final medical impressions and diagnosis, the diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated with hypertension, dyslipidemia, neuropathy, retinopathy, and microalbuminuria. Thank you.